Welcome to the next episode of Med Matters, an education podcast for everyone who loves teaching and wants to learn how to teach. We have Dr. Sripad is back with us for today's episode. Hi, how have you been?
I've been great. Thrilled to be back.
Tell our listeners what you've been up to.
Just being busy clinically and all of that, and then I'm currently on vacation in Hawaii, so very much enjoying that.
Must be nice. Must be nice.
Nothing breaks a vacation like some discussion on medical education, though. So very happy to be here.
Well, we are happy to have you back. Today's topic is feedback in the clinical learning environment. You got a minute to chat about it? We have two very special guests who are going to have an interesting discussion about feedback today. We have Dr. Jes Morse. She is our residency program director here at UNC. And we have Dr. Steve Dudick. He is our OB rotation director here at UNC. I will let each of them introduce themselves. Dr. Morse.
Hi, thanks so much for having me, Dr. Young. My name's Jes Morse, and I'm a family planning specialist and also the residency program director here at UNC. Um, and I am actually so excited to be on this. I love medical education, and I am completely IT not savvy, but I have loved listening to these podcasts, and so I'm excited to be part of it. So thanks for having me.
Thanks for coming. Dr. Dudick?
Thanks for having me. I'm Steve Dudick. I'm also a member of the faculty at UNC. I work as an OB hospitalist clinically. Previously been a clerkship director, and as you mentioned, now work with Dr. Morse to oversee the obstetrics rotation of our OBGYN residency program.
Thanks, Dr. Dudick. We are so happy to have you here on the podcast. We as clinical educators know that one of the most pressing topics and one of the most frustrating topics is feedback, both giving it and receiving it. So, my first question to everyone in the group is when you hear the word feedback as an educator or as someone who has gone through medical education, what comes to mind?
I guess I can go first in that thinking of how that word, landed during training. I had a chief resident always emphasize to me the importance of labeling when I was giving feedback to med students or, as a senior resident. And there's a lot of virtue to that. But I think when that happens and you're getting feedback, there's a slight moment of unease. Your back kind of sits a little bit straighter, your heart rate goes a little higher. And through no kind of fault of anyone else, I felt like there was always an assessment or judgment in that. But now on the other side, I realized it really couldn't be different. You're just trying to provide somebody kind of like real time direction. And the thing that I think is all of us can attest to at the end of the day, you just want your trainee to be better than they were when they started the day. And that's sort of the role of feedback, whether it's a small minute point on technique or, something bigger. It's not this component of judgment or, overall assessment or anything like that.
Dr. Moore?
I laughed when you said it because I think two extremes come to my mind. One is tears and one is love. And I think as a program director, people get that, like Dr. Shripad was saying, there's some palpitations when they know they have to have feedback with me. But I really try and jokingly say that feedback is love. And again, I think we're not doing our jobs as medical educators if we're not giving a lot of feedback, because as was just mentioned, this is about growth and becoming the best in our world OBGYN that you can become. And so if we're not giving feedback, we're not allowing that process to happen in a productive way. And then one other thing I would add is as faculty, we also need feedback. And I don't know that we get enough of it, but I think this is how we grow as humans. It's not just about trainees, even though that's what we're focused on. And so I think it should be something that we are happy about and proud of, that people care enough in our, not about us as a human, but about us as a learner and growing doctor to give us feedback.
Dr. Dudick?
I'll just echo what Dr. Shripad has said is that feedback is not typically announced as feedback. And I remember how I, as a learner, had to recognize it in the moment. Certainly you have your more formal feedback sessions where you meet with your program director, you meet with your clerkship director, but I also think of the passing advice that I would get from my attendings in the operating room, little tips and tricks that they would have from their experience. When I'm presenting patients to a senior resident and they're asking me, did you ask about this? Did you ask about that? That's feedback. If I didn't ask those questions of the patient, those are questions I should ask a future patient. And then to challenge myself to go back and understand why I should have asked those questions. And then ultimately in clinical practice, your patient outcomes are a form of feedback. And you can tailor your practice based on how people have responded to the care that you've provided. I would also echo what Dr. Morse had said about faculty also needing feedback. Certainly, we think about feedback from a teacher to a learner, but equally important, I think, is feedback from learner to teacher so that we can become better instructors.
Yeah, I would echo everything that you all have said. I think, feedback is basically something that's, imperative to growth. And we can't actually teach without letting a learner know what they have done well, which I don't think that we often do, as well as letting them know what needs to be corrected. Um, but this brings me to another question. So, and I think I know the answer, but I'd love to hear your thoughts. Why is feedback such a tough subject in medical education? And I'll throw it to Dr. Morris as a program director.
I think it's hard because people assume that it's going to be negative and that they're not doing a good job. And I think part of that just comes from our field. In medicine, it's really important that we do a good job. And when we don't do things well, they're potentially bad patient outcomes. But I think the trick here is that we're working with learners and they can't be expected to do things well until they have gone through a process of learning them. And so I think having the assumption that feedback is a part of that process can take away some of the negative feelings that go with it, because it really is an important and fundamental part of the process. I think the other piece is that it's really easy to take it personally, and feedback really should be about behavior, not about a person and their personal attributes. And I think as educators providing feedback and as learners, again, even lifelong learners, as faculty receiving feedback, we're trying to grow in our roles and remembering that this is not about me, Jes. This is about my performance and my behavior, so that I can hear it in a more objective way, and allow myself to improve.
That's great. So for our listeners, I think and you can correct me if I'm wrong, I think what Dr. Morris is saying is that in any clinical learning environment, you need to establish expectations that you, one, will be receiving feedback, two, that the feedback is meant to make you a better version of yourself than you were when you started whatever you were starting, and three, and we'll get into this a little bit later, it's not meant to be necessarily punitive, attacking, or anything like that.
And I,
Um,
sorry,
but
Dr. Young, that better version of yourself as a physician. So
mhm,
I am not in a role as a medical educator to make you a certain kind of person. I'm trying to help you become an excellent surgeon or clinician. And I think it's removing that, like, who am I as a person part that makes it a bit
100%,
easier to hear.
100%. Dr. Dudick, why do you feel that feedback is so important for trainees?
Residents have heard from me many times when I'm offering corrective feedback is that nobody comes into residency knowing how to do all of this. And so much of medical learning, especially at the resident level, is self-directed, really with minimal external guidance. So I think direct individualized feedback really provides our trainees with that outside perspective that they need of how they can prioritize their learning. It can help identify specific areas that they can target to improve their overall performance. I think it's hard to do that if you can't get outside of your own mind, and having that external opinion can really be helpful in trying to become a better physician overall.
Right. I mean, we wouldn't need to have training programs if we assumed everyone should be able to do everything once they are working with us. And if they're not able to do them, then we should teach them. And if they're still not able to do that, then perhaps we didn't teach them effectively. So, and we always like to put the blame for um, deficiencies in education on our learners, but we need to focus on what deficiencies as we as faculty have in that whole learning process. Any thoughts, Dr. Sripad?
Yeah, I think just to echo what both Dr. Morse and Dr. Dudick said, I think when trainees come in, especially junior trainees, there's no prior experience like residency or even medical school. And so I think kind of thinking of you're building this new version of yourself or version of part of yourself can really be sort of directive and more positive that you have all these great ingredients from your prior experience, your, general personality, your sort of kind-heartedness, good-heartedness. But, if I can give you real-time feedback in the moment, which may, I think we're all busy. We can't always, phrase things in, the most palatable way at times. Sometimes it's very quick and direct, and it's not meant to be, personal, but more to add to this kind of part of yourself that you're building, which is you as a physician.
So, for our listeners, I want to step back just for a second and have a really clear understanding of what we're talking about. So, let's all define exactly what is feedback. So, it's a word that we hear all the time in the clinical learning environment, but exactly if someone asked you, Dr. Dudick, like, what is feedback? What would be your definition of feedback?
I would say feedback is insight that one provides to somebody else regarding their performance, whatever that may be, that is really intended to serve as a basis for improvement. This can be anything from attending to a resident or a medical student. It can be peer to peer. It can also be, as we mentioned before, from learner to teacher. And feedback in that sense can include reinforcing behaviors and actions that you've seen that you want the recipient to continue, and also correcting behavior and actions that you would want them to change or avoid in the future.
So, you think feedback is bi-directional?
I do.
Yeah, yeah.
Yeah.
Dr. Morse?
Oh, I would agree. Um, I was just, it's almost hard to articulate the difference between assessment and feedback, but assessment is in some ways a more sort of objective evaluation or measurement of performance. The feedback part is now me providing this more, not necessarily subjective, but evaluative component to it. So, for instance, a test is an assessment. And we know that getting a 12 on a test, the feedback is probably going to be you're not meeting the mark right now. But the assessment was just this more objective measure of performance. And it's that next step of, as an intern, like that's actually a reasonable place for you to be right now. As a chief, I'm really expecting you to grow into this when you're next taking this assessment. Sort of, it's that more evaluative growth component of assessment.
Yeah, for me, when I think of feedback, it's like what are specific things that we are looking at, either a task. Let's essentially say just a task. And then if you put everything of that collectively together in the context of, say, a rotation, a week spent with an attending, or what have you, then you can make a summative assessment of that learner's ability to achieve, let's say, a milestone, right? And so for me, feedback is something that is very, very specific, and we can get into that in a little bit. Dr. Sripad, in your practice, what definition of feedback do you use and why?
I like to actually think about it a little bit with an analogy. It's something that I think we can all relate to. It's kind of like how we all learn to drive or driver's education. So, we all had some amount of coordination that somebody thought it would be okay when we're 16 years old to get behind the wheel. But there were hours that we had to log, if I can remember correctly, with, an instructor. And in that time, it wasn't like if we forgot to put on an indicator or, didn't break at a certain point, it's not like we were off the road forever and ever, but there was sort of a directive feedback in that time frame over those hours. As a culmination of that experience, and then with your test, when you learn to drive, that's sort of like that assessment. So I almost think about it similarly. Obviously, the leap is a little bit more complicated with medical education, but when you are sitting in the car with your trainee, you're sort of giving that indication of, hey, I think you should slow down here, maybe don't, blow through the stop sign there. But it's not like you're taking them off the road. You're not, being punitive about it. But exactly like you said, Dr. Young, at the end of the rotation, if they have more kind of like objective assessments, that might be a time where, you know, you sort of understand where all that work culminated to. So that's how I like to think about it.
And when do you all provide feedback to your learners? When does that occur in the day to day of, seeing patients, billing, teaching, counseling, following up your labs? When does that feedback happen? Dr. Dudick?
I tend to do it at two different occasions. One, I try to give specific feedback in the moment. But at the end of the clinical day, say I'm working in the clinic with a student and they give me a presentation on a patient, I give them feedback on their presentation, how I might recommend they do it differently next time. At the end of the day, I'll always ask a student, so what did you learn today? And hopefully what they'll end up doing is summarizing the feedback that they had received. And that starts a conversation then for us to dive into it a bit more and have an ongoing conversation about their performance and what they could be doing better.
And Dr. Morse, what if you're told by a faculty member that says, I don't have enough time to provide feedback and I don't frankly think it's my job to do that? Can't you do that as a program director? What would you say?
Well, I have that conversation quite regularly. I think one of the key parts of feedback is that it needs to be first based on firsthand information. That's not always possible. And as a program director, I'm often working in circumstances where I'm giving feedback not based on firsthand information. But I think in general, we really want it to be based on observed behaviors. That makes it much more objective. And we also want it to be timely. So me talking to a resident about something that happened 3 weeks ago with a different faculty member involved has a really different value than the faculty member who was involved in the scenario talking to them in a more time appropriate manner. I think the time part is complicated because at the end of a 24-hour shift might not be the right time for someone to be able to hear feedback, whether it is good or bad. It is, people's ability to grow and openly hear things is not great when they're exhausted. So I think it is important to think about the setting. But I think the bigger things are that it's really important that feedback really be specific and actionable. I think Dr. Dudick already brought up one of the other key issues is having the learner reflect back, having something that is able for them to put into motion for themselves so that they can grow from that feedback.
So you two bring up this acronym that has been bounced around in medical education for years. It's something called the SMART acronym. And if there's one thing that you take away, listener, from this podcast, is the SMART acronym. So Dr. Morse and Dr. Dudick have mentioned that feedback should be specific, it should be measurable, it should be actionable, meaning that a learner can actually follow through and do corrective behaviors. It needs to be relevant and it needs to be timely. So, Dr. Sripad, you are a urogynecologist. So let's say you have a resident with you in your office. Um, Tell me how you would use the SMART acronym in your practice.
Yeah, I think even before kind of unleashing the smart, paradigm, it's good to know what the residents' goals are and where they start. So it's almost they set the acronym in place. So, say this is the first time I'm working with them, understanding how many patients with prolapse have you seen before? How many exams to assess prolapse have you done before? And sometimes the specific goals and specific things that the resident is working on sort of write themselves. And I think that you can establish that with a few questions up front and just a way to understand where they are. And in a certain sense, that kind of builds this framework of, okay, this is what we're going to work on. This is what I'm going to kind of be, really having my attention on you for to kind of direct you for doing things, spot on, or do we need to tweak something? And it sort of takes that element of, again, sort of like the judgment day part of it out of it, where, okay, like my attending is looking at how I do pop Q examinations. Like if I don't do it correctly, then I know I'm going to get some kind of feedback throughout the day and at the end of the day. So, specifically how I kind of approach it in the office is, starting with the trainee establishing their particular goals and then kind of letting them know how I provide feedback, which is like throughout the day. And I might kind of slip it in between when we're going from one room to the other. And then at the end of the day, we'll try to, touch base. I think sort of setting the roadmap like that tends to help with understanding right place, right time. And then, if it doesn't happen perfectly with that timeline, I think, residents tend to understand that because you put in the time and effort to kind of set that plan with them at least.
So I love that you basically are involving the learner in their own learning. You have built a scaffold, right? Because you know exactly where they're starting from and you know how to gauge what you need to teach them. And I think that makes for a fruitful experience, not for just the learner, but for you as an educator. And then you can provide that timely, relevant, actionable feedback to that learner. But then I'm really confused though, because why are then medical educators so scared about providing feedback? What do you think, Dr. Dudick?
It's a good question. It's hard to speak for all medical educators. I think one concern is that negative feedback specifically is sometimes received poorly, and it can cause feelings of stress or inadequacy in the recipient of that feedback. There may be a perception that then providing negative feedback can can adversely affect a teacher-learner relationship moving forward. And I think when you're working so closely with your learners day in, day out, uh, that's not a relationship that you want to see break down. And educators themselves are not immune to those same negative emotions. Again, it's hard to speak for all medical educators, but some may have a concern that by providing negative feedback, an educator opens themselves up to receiving negative feedback from their learner. And that might be enough to shut down the exchange of feedback altogether.
But as you mentioned earlier, the feedback should be bidirectional. So if we are wanting our learners to accept this information, we should also be accepting of this information to be better clinician educators. Um, so, Dr. Morse, how do educators learn to provide feedback?
I think some of it is doing some of what we're doing now is like having some of these tools to do it in the kind of most constructive and productive way. So using the SMART idea and as Dr. Shripad said, kind of setting expectations from the beginning, engaging the learner from the beginning. I think also just doing it. And realizing that actually it's not so scary and painful, and it's actually really productive and helpful. Um, all of us have I think most of us who've been in med ed long enough have had feedback experiences that don't go well. And so I think also really learning from those. I think at the end of the day, just remembering we are adults, we are working with adult learners. And so if we can all keep our sort of bigger objective goal in mind, that I am doing my trainees a disservice if I do not do this. I'm not actually doing my job. And so if I care about my patients, if I care about the future of our field, this is part of what I do. And I get better as I do it, just like everything else.
I agree. So it's this point in the podcast where we talk about our med ed moment. This is the one thing that we want our listeners to take away from, or if you're watching on YouTube, what you should be taking away from this podcast. So, Dr. Shripad, what is your med ed moment?
I think one thing that came up through all of our reflections has been maybe sometimes there's a negative expectation around feedback. My meta moment is that, we should try to reframe that, in that, this doesn't have to be punitive. This can be something that we're looking to build together, which is, trainees that are better equipped to go out and practice independently. And also, like Dr. Morse said, for ourselves to be better educators and to have it be a better experience for ourselves. So, sort of reframing the negative expectation is my med-ed moment.
Dr. Dudick, what is your med-ed moment?
Would echo a lot of what Dr. Sripad just said. We all have our blind spots when assessing our own performance, and so I certainly know I have mine. I would challenge all of us, including those watching and listening, to think of feedback from a teacher, a peer, a learner, positive or negative. Think of it as a valuable resource that we can use to become better clinicians and teachers.
Dr. Morse, what is your med-ed moment?
I think kind of uh, following along both of those comments, I think just creating this culture of sort of humility and engagement in the process of growth and learning so that we are all invested in this idea of moving forward. And so feedback is part of that. I think as clinicians, like that is inherent. Like you would never stop reading journals. You would never stop trying to figure out better ways for your patients to get the care they need, to make them more comfortable, to make their lives easier. And so this is part of that process. And so I think just creating this culture of feedback being part of how we grow as clinicians and this sort of culture of feedback and humility and growth.
I couldn't have summed it up better from all of my three guests. This is great. Um, if you have any other questions, please feel free to reach out to us. But this has been a really great episode. Please provide us with hint, hint feedback on today's episode. And we will look forward to welcoming you on the next episode of Med Ed Matter. Thanks for having us.